Hi everyone, this is Soosan Jacob, and in this video I'm going to show you a case of Endoilluminator assisted Pre-Descemet endothelial keratoplasty in a patient with a graft failure. So you can see that I have taken the donor cornea and I've got a 30 gauge needle fixed onto a 5cc syringe and I'm injecting air. Since I could not see any larger air bubbles forming, I have shifted over to viscoelastic dissection and I'm going more and more superficially till I get a type 1 big bubble formed with viscoelastic. Now, I've already measured the diameter of the existing failed graft in the patient's cornea, and I've tried to take care to not extend the bubble that is formed to a size that is greater than the recipient graft. This is important in order to avoid a situation in the intra and postoperative period of the E-PDEK graft turning out to be larger than the failed graft in the recipient cornea. Now this is the patient's cornea and I'm removing the epithelium in order to get better visualization. We can see that the recipient bed measures 8 millimeters and so it is about 0.5 millimeters larger than the graft obtained. I've made a side port and a main port because we're also planning to do phacoemulsification in this patient as he's got cataracts changes as well. I have stained the capsule with trypan blue and performed a capsulorhexis. Once the capsulorhexis is completed, the nucleus is mostly very soft and it can mostly be removed just by doing a good hydrodissection followed by irrigation aspiration. Since visualization is not very clear, I am using the Endoilluminator shown externally in an oblique manner to enhance visibility and help me in removing the cortex more easily. Once the bulk of the cortex has been removed, you can see that the red glow has improved dramatically. Care is taken to remove all the cortex and then the intraocular lens is implanted into the bag. A thorough viscoelastic removal is then done, taking care to remove all the viscoelastic from the anterior chamber. Once this is done, I make a side port for fixing in an anterior chamber maintainer and then I do a descemetorhexis from the posterior surface of the graft. E-PDEK or Pre-Descemet endothelial keratoplasty was described by Prof. Agarwal and Prof. Dua. And the difference between the E-PDEK and the E-DMEK graft is that the E-PDEK graft also contains the Pre-Descemet layer or the Dua's layer in addition. The E-PDEK graft has advantages of being able to use younger donor corneas as well as being more resilient and tough and more resistant to tears. Once the graft has been injected into the anterior chamber, we can see the poor visualization of the graft with just the microscope alone, but with beautiful visualization once the Endoilluminator assisted technique is used. This was first described by me in 2014 and since then all the cases of E-PDEK that we do is done only with the Endoilluminator. I'm now opening up the graft using just the E-PDEK technique alone and with the microscope light switched off. Since there's been some amount of pigment dispersion, I've washed it out and now we've got the E-PDEK graft centered reasonably well in place, and once this is done, I go right to the back of the E-PDEK graft in the center of the anterior chamber and inject an air bubble to float the graft up. You can see that one of the edges is folded and I've gone into the space between the host stroma and the graft and I have unfolded the folded edge. This is the post-operative day 5 appearance of the patient and you can see that the cornea has already started to clear. His best corrected visual acuity is 6/18 or 20/60. At 3 weeks post-operative, he has got an uncorrected visual acuity of 6/12 or 20/40 and a best corrected visual acuity of 6/9. At 6 months, he continues to maintain this with a best corrected visual acuity of 6/9 or 20/30, and you can see a very clear graft which is non-edematous and a well-positioned intraocular lens. The patient was extremely happy because he improved from a pre-operative visual acuity of 6/60 or 2200 to a post-operative visual acuity of 6/9 or 20/30. I do hope you enjoyed this video. Thank you so much.